quickly I'll be sharing my slide from this end. I believe you all can see my screen. And give a thumbs up or a heart if you can see my screen. All right, thank you to Anime. Thank you, blessing. All right, so this session is supposed to be an innovation ideation session / networking, meaning that people within the audience would talk, get to know what you do, and then you share insights, and it's based on your experience or from your perspective on how we can make this challenge better, the brain drain bridge. So if you started the workshop with us during the first session, you remember how Dr. Abiero stated that virtually everyone that graduated with him in school is no longer in Nigeria. The number he gave was, I believe, about 80% of his classmates are no longer in Nigeria. And that applies to many other sets. So many doctors are leaving the country for many reasons. And it's alarming. I mean, it's a state of emergency in the healthcare system. And this also applies to other healthcare professionals, not just doctors. We have so few nurses, so few physiotherapists, pharmacists, and all different categories of healthcare professionals. So this afternoon, we will be engaging one another. The focus of this session is largely on the medics, how we can come up with tech interventions to bridge this brain drain gap involving the doctors in diaspora. So the core idea is this: Nigeria does not just have a shortage of doctors, we also have a distribution problem. So we have the expertise, and the challenge is how do we plug it back into the system efficiently? So the truth is, I know for sure, I know categorically that many people that leave, I speak for doctors now, many doctors that leave the country do not just leave without having home in mind. A number of them have it in mind to give back to Nigeria. They want to help Nigeria to be better. They are very aware of the problems that we have currently in the country, and they look for ways to actually make positive impact. And one way that we want to explore, one idea that I want to explore this time around is how we can incorporate telemedicine. Telemedicine has been around for a while. We've adopted it for follow-ups, for post-op. I mean, it can be adopted for follow-ups and post-op reviews. I mean, and it has been adopted for that in so many other instances, for disease management, like chronic disease like hypertension and diabetes, mental health or psychiatric consults, even teleradiology, where expert radiologists are invited to review imaging. Then for dermatology, which is quite easy, largely image-based, they offer treatment plan based on images that are seen. And then we get second opinion for complex cases. One that may need a form of hybrid model would be acute care triage, where you will need to do a bit more on site than virtually. Pediatric assessment, because that category of are largely delicate. Neurological exams, because you need to it is possible with guidance, but still limited. Even it's not limited to neurological exams, in fact, general physical examinations, but neurological exams because I kind of have a bias for neurology. And then largely telemedicine is not suitable for emergencies requiring intervention, like immediate intervention procedures. Although this, regarding the procedures, there's telerobotics, surgeries are done miles apart. I mean, technology has made medicine and surgical practice very beautiful. And for unstable patients, so again, patients that may need urgent intervention. Yes, I've been doing a lot of talking. We'll soon get to the part where other members of the audience would share their insights. But there's a problem that I think a doctor in New York cannot legally prescribe directly in Nigeria without local licensing. And one thing, a way I believe we can circumvent that is if we have that diaspora doctor as a consultant and the local doctor to do the one that will prescribe um, on record, the prescription that will be available on the record. At least that would the licensing program is circumvented. This is just an idea, and I think it's applied, and I like to think it's a good one. You would share. Well, okay, I think this is where my first question should start, or or before then. Okay, so let's go to this one is more engaging. We aim to build for Nigeria. Dr. Imodui emphasized during the session how irritated he is about how we import even the basic things, and that contributes to the existing cost of healthcare in the country. We should be manufacturers of certain things, but bringing it home to technology now, because this is an edtech space, we want to design the technology, and we are designing for Nigeria. We're not designing for Silicon Valley. We're not designing for the US. But what telemedicine, the disadvantage that comes with telemedicine is that it favors more fast internet, very good smartphones, continuous connectivity. But that is not the reality we have here. Yeah, you can argue that many people, many young people, many middle-aged people currently have smartphones, there's fast internet, but it's something I see very often that they do not have data. They don't have data on their phone, and without data, you cannot access the internet. Why don't they have data? Because they don't have money. Why don't they have money? Because nobody's jobs. The jobs they are doing are not paying enough, or they don't even have jobs at all. I mean, the problem exists at different levels, but we want to have a solution that recognizes these problems and then solves them. So the design proper. I want you to bear in mind that if it doesn't work for poor network, because that's the state of things in this part of the world, it doesn't work at all. If what you are thinking about has to run on 5G, if you go to certain parts in Ibadan, for instance, you will not have that. Or I don't remember the name of Dr. Emode's village now, where you have to get on a boat ride to get there. But I like to think technology and the network there in most places there will be poor as well. So and most people in remote areas, in rural areas, they still have this problem of poor network. So if your solution is not targeted or does not help them, people at the grassroots, you may not be doing a lot of people favors. But yes, so there's this idea where we have a low bandwidth architecture. It's a tier system, meaning that it's in layers. There's nothing rigid about it. It can accommodate the different problems that exist. But I've been doing a lot of talking. So, but before we get to this, how do you think we can circumvent this problem for network? I'd like to hear from the audience. I know a number of people have spoken during the course of the workshop since it started a couple of hours ago. So does anybody want to share any insights? I see Messi Awoshika on the call, Ngozi, Bruno, Oluwapelumi Ala, okay, spoke earlier. The session is meant to be interactive. So if you are not interacting with me, you are not exactly meeting the purpose. All right. Let's just go a bit deeper. Hopefully, you have questions, suggestions on how to make this idea better. So, bearing in mind how we need low bandwidth architecture for most things to work, so we can have what do you think about having a system that adopts the USSD layer for baseline access, you can use shortcodes. Like if you want to book an appointment with a doctor, with a cardiologist, for instance, just dial *123#. And then here we have basic triad questions. Then from the shortcode as well, you can get further responses. And then there'll be a queuing system where as you come, as the questions pop, you get the responses. Then it is important to also bear in mind that we should have a focus for audio first before videos. It's videos require higher bandwidth, that is, if you want the resolution to be preserved. And then even if you are starting with video, you would want an auto switch to audio in case that bandwidth drops. Just to, once there's audio connection, communication is still preserved. And this idea could also have a store and forward system, largely for images and lab results, where you can, for instance, take pictures of skin lesions and send to a dermatologist somewhere in Ontario, Canada, or you have your lab results for somewhere for a specialist nephrologist somewhere in diaspora as well. They are able to review the results of the images asynchronously. And last thing is, because we may not have internet access at the time when the images are shared, or when the condition is required to be made, or when you want to share your lab results, the data should be able to be saved locally, and then once there's internet access, you can sync it up. So the big question, or the big model, the virtual presence model, where we are wondering, how can we make a doctor in New York feel like they are standing in Ekiti? Okay, I chose Ekiti there because I am from Ekiti. I'm sure other people, I remember in the audience, people were stating where they are. I remember somebody from Ondo, Omosho. So if you're a doctor, or how do you want to make a doctor that is somewhere in New York feel like they are with you in Ogbomoso or in Ondo City? Now, I really need your insights. What do you think we can do, bearing in mind the challenges of telemedicine and how we think we can go around that? And now we want to come up with a model where a doctor somewhere, a specialist somewhere, is needed for a patient in a remote area. TikTok. Nobody's saying anything. Is there a paucity of ideas, or you're shy to talk? Okay, thank you, Oluwapelumi. I see your hand. Yeah, it's on a bit distant. Could you speak louder? Barely.
Better now.
Yes, much better.
Yeah, so I feel the first way is maybe, like you have said, a video conferencing to make it as if they are standing, at least you're seeing the person. Then there is also virtual reality. I don't know much about, but I think there's something like that where you can assume that you can see the person, but the person is not necessarily standing in front of you, but you can see and you are conversing with such person. So that's what I have out of the past.
Okay, virtual reality presence and video conferencing. Well, thank you very much, Oluwapelumi. Does anybody have other ideas? How can you make a doctor millions of miles away see your patients in your remote setting? All right, Dr. Bayori, I see your hand.
Thank you for the question. It's quite intriguing and important to know that care is usually multidisciplinary, and that means it's not just the doctor. And I believe that's where a lot of telemedicine becomes tricky. I also so I believe if there's a way to synchronize care and have input from various specialties, disciplines in quotes, I think it would improve the virtual presence. Other than that, the fact that a doctor comes in, logs into the telemedicine platform, attends to these patients, and then the next time the patient, same patient comes in and it's another person, that might deter the continuity of care. And in situations where proper record isn't being ensured, or um, protection of privacy in which they cannot exactly follow up from the previous conversations. So I believe a way to bridge these gaps, getting investigations and then reviewing in a way that maps maybe previous history to the person seeing the patient now, or um, depending on the availability of the doctor, it can continue that care with the person that saw before in a very robust manner. It can be tricky to implement, but there should be some form of workaround. The video conferencing and not just chatting or using voice. I believe one of the very fundamental principle of medicine is actually saying, and since this is virtual, at least the highest form of presence should be ensured, which is video. Um, Also, a form of combination with a physical visit, maybe a referral from for some conditions or diagnosis would bridge some gaps. Um, I think that's my own input from that.
Yes, thank you very much for your input, Dr. Bayeri. Yes, you emphasize the importance of um, health records, why that may be, if not properly implemented, it can distract or even disrupt management plans. I think another thing you emphasized was how it's important to be as present as possible. Audio definitely will not do as much work as a video presence would, which is very true. And so yes, bearing all of this in mind, let's continue with um, the model that is there. So we can suggest modifications to it based on our own ideas. Yes, also from what Dr. Byron said, the healthcare system is not just about the doctor. I mean, there are other healthcare professionals. Those that receive the patients, nurses, they have a role of checking and its vital signs, provide nursing care to patients. Well, for one of the things that we do, for the purpose of this presentation, when at the local sites where the patient comes, we should have, I mean, this idea believes that we should have a nurse who or a community healthcare worker who should be able to handle a digital stethoscope. Digital, you would see why I said digital. Then a pulse oximeter, a BP monitor, a tablet, and a phone to communicate with the doctor or to interact with the platform where the doctor will be engaged. Then the remote specialist knows where access by the doctor being reached now. They'll have access to the patient's vitals, live audio, the medical history can be taken, and then instructions on physical exam as well can be given as needed by that doctor. And then a way of interacting further to the um, engagement by the doctor in diaspora. So yeah, w- eh, think of how the doctor can directly listen to the patient's chest. Say, for instance, the patient presents with difficulty breathing, and you're suspecting that, oh, this person have pulmonary edema. What you expect to hear is, oh, there may be widespread palpitations. And if, for instance, the person that received this patient, if person may, unfortunately, the person may not be a doctor and is unsure of, oh, what am I hearing? And then the doctor should be able to say, okay, just put the state on the person's chest and let me hear what it is or what the chest is like. And then doctor listens, nurse executes, and to be able to arrive at a potential diagnosis for that patient. And then enabling technology, something that is on the low end, Bluetooth enabled devices, because those are inexpensive, low data audio streaming, compressed signal transmission. All of this would, I believe, to a large extent, help with that virtual presence of a doctor. What do you have to say? Does anybody have any insights, any inputs, any questions to ask regarding this model? Anybody? Okay, Messi, Awoshika, I see your hand, please.
That the model is okay, but I was thinking that can a doctor also make use of a programming language like maybe R or Python, probably to analyze the patient's records to know which area to focus on or the effects of whatever medications is given to the patient. That's what I just suggest. Maybe it's possible for a doctor to also learn programming languages. I think that will also help in medication too.
Okay, thank you very
I
much.
don't know much of it.
Uh, yes, thank you for your feedback and contribution, Messi, Awoshika. Well, a doctor does not need to make use of a programming language to do those things that you suggested. Of course, it may be helpful in other instances. They may be, I mean, programming languages may help with building the platforms, yes. But as far as the clinical decisions or engagement that the doctor will make or regarding that time of interaction with the patient, in my opinion, I don't think that any program language would be required to do that. But of course, they can be useful in other instances. Again, thank you for that contribution.
Thank you for explaining that.
You understand it. Do you have more to say?
No.
So do we have contributions from other people in the audience? All right, so well, let's go on to the next slide. So the workflow of this system is that the patient comes, seen by the local nurse, then the nurse engages the tech platform, which the hospital doctor also does. Then the local doctor is involved in this sense for in case any prescription is required. That is, if the hospital doctor is not licensed to prescribe any medication, and then the patient receives the care at the end of the day. So now this before I show this slide, I would have loved to ask questions from people in the audience. Now, why do you think telemedicine has failed so far? I'm sure there have been a number of platforms, innovations where people have tried to make healthcare better, at least for people in rural settings. But why do you think we've not exactly tried so much in these clients? Well, I have a number of responses here. but in case you have more, I'll be happy to hear them. There's little to no integration into hospital workflow. Most hospitals that you find around are still into the system of physical engagement with their patients, and most sadly, if you speak to most management about it, they do not foresee how telemedicine can come in because they are more focused on the challenges around it. Uh, so yes, that leads me to the second point, that they do not trust the system. There's this fear that, okay, for instance, records could be hacked. There's no security for these networks. Poor documentation is another problem. Going back to the point that Dr. Obayori made about how health records may be a drawback to or is something to focus on when we are trying to ensure virtual presence. So far, the problem of poor documentation has contributed to the failure or to the reduced progress of telemedicine. And no incentives for the aspirant doctors. Uh, Incentives mean, yeah, I mean, they go a long way in helping people stay interested in certain opportunities. And even beyond the diaspora doctors, even incentives for local doctors could also be very instrumental in helping some of these innovations thrive. And then there are so many regulatory gaps, many of which, if I start to talk about, we have to extend this a bit further. So, Blessing is raising her hand. I believe she has something to say.
Yes, I would like to contribute to why telemedicine fails in Nigeria. I would say, like, for most hospitals, there is no centralized database. And I don't even think it should be limited to hospitals alone. I think it should be like there should be a database for everybody's health information. So regardless of whether another doctor is in diaspora or not, someone could be probably domiciled in a particular state, maybe Lagos State, and they traveled out of Lagos to probably Ibadan and probably had an accident or an health emergency, right? So there should be a centralized database where if the person's name is imputed, they can get all of the information. You don't need to start running tests to know the person's blood group or all those vital information. So I think that if we have a centralized database, it's going to be like a step in the right direction of making telemedicine work in Nigeria.
Yes, thank you very much for that contribution. I totally agree with you. It's important for us to have a very good database, centralized database. And sadly, it appears that we are still miles or years of years away from that, sadly. So how do we make it work? These are just a number of suggestions. Of course, there are others. I mean, you can suggest a bit more before we end the session. So give incentives to consultation should not be free. Then offering volunteer credits and impact tracking that would encourage local doctors to be interested in being a part of these kinds of innovations and initiatives. And academic collaborations that would give credence to your work. That will encourage people to subscribe to your idea. That would even encourage local doctors to give their input because they believe that people largely want to get their names out there. Then regarding policy, we could get temporary telemedicine licensing partners with the institutions like the Medical and Dental Council of Nigeria, major hospitals across the countries like University College Hospital, Ibadan, and federal medical centers across the country. And for trust, of course, certainly use verified doctors only, and licensed doctors, core professionals. Then you follow standard protocols when you are delivering care, and then document properly and integrate very well with your electronic medical records. So these are just a list of ideas that I believe we can consider when we want to try to make this initiative work, the brain drain bridge. What other ideas do you have? How do you think can make the medicine work? Okay, Blessing is raising her hand again.
Yes, Still a contribution. I believe that since this is a health tech workshop, we've brought the problems from the health perspective, so we can actually look for solutions from the tech perspective. I know that even if there are third-party solutions to this, the what's it called? The effect we can have may still be minute because we have a lot of people in Nigeria. But what if we can probably think of possible solutions to this problem, possible tech solutions, and have everybody pitching on what solution can work? For me, I feel if we have like a database, I don't know the data implications or policies for health, at least health-wise, right? But what if there's like a third-party app or website where people can input their information? What would we need to build that kind of app? Do we need licensing from the government? Do they give that kind of license or not?
Thank you, Blessing, for that question. Does anybody want to offer a response? Is anybody in the audience? Are we still listening? Okay, Oluwapelumi is still with us. Well, okay, in the absence of any contribution or any further contribution from the audience, but I would say what you raised are many more things to consider when we're actually thinking about solutions like this. Ensure that before you start, you confirm local rules, institutional regulations that guide certain initiatives, policies that the government have laid down before implementing certain solutions. So one won't go a long way in extending certain solutions to the public, while in the long run going against certain rules and regulations that have been laid down by the government. I think that's my summation for that question. So the goal is telepresence, where clinical distance disappears in clinical care. That's is what we would try to achieve with this idea, hypothetically. So if we have further questions, if you have further contributions, you can always reach out. This was supposed to be as interactive as possible, but sadly, I only heard from just a number of people in the audience. So do we have questions before we move on to the next session? So in the absence of further questions or contribution, I'll be heading on to the next session. I'll be anchored by Adiriti Adipobola,